Excision of malignant tumor of maxilla or zygoma. The physician excises a malignant tumor from the maxilla, upper jaw, or the zygoma, arched cheekbone. Incisions include transoral, e.g., maxillary buccal vestibular, and facial, e.g., Weber-Ferguson. The bony mass is excised with the use of drills, saws, and osteotomes. Some surgical defects may require immediate soft tissue reconstruction, e.g., myocutaneous flaps. Transoral incisions are closed in a single layer and facial incisions are closed in layers. Excision of malignant tumor of mandible. Radical resection. Through an intraoral and/or extraoral approach, the physician isolates and dissects the mandibular tumor. The tumor and surrounding tissues are removed. The tissues are closed with layered sutures or may be packed and left open. A separately reportable reconstructive procedure, such as bone harvesting, may be necessary. Resection or removal of a part or all of the mandible is performed. Immediate or delayed reconstruction with bone grafts, tissue rearrangement, flaps, or prosthetic devices is sometimes required. The skin incisions are closed with layered sutures. Excision of rectal tumor by proctomy, Trans-Sacral or Trans-Coccygeal approach. The physician removes a rectal tumor through a Trans-Sacral or Trans-Coccygeal approach. The physician makes an incision at the junction of the sacrum and coccyx. The coccyx is excised and dissection is continued posteriorly to mobilize the rectum. The tumor is identified, an incision is made in the rectum, proctomy, and the tumor is excised. The rectum is closed with sutures or staples. The initial incision is closed. Excision of rectal tumor, transanal approach, not including muscularis propria, i.e., partial thickness. Including muscularis propria, i.e., full thickness. The physician removes a rectal tumor through a transanal approach. The physician explores the anal canal and exposes the tumor. The tumor is excised to include a full thickness of the rectal wall. The defect in the rectum is closed with sutures. Excision of lesion or tumor, except listed above, dentoalveolar structures, without repair. With simple repair. The physician removes a lesion or tumor of the dentoalveolar structures. If the lesion is within the mucosa, the physician makes incisions around the lesion and dissects it away from adjacent structures. If the lesion is within the bone, the mucosa is incised and the underlying bone exposed. The lesion is removed from the bone and the incision closed with layered sutures. No repair is done. Indiana 41825 and simple repair of the surgical wound is done. Indiana 41826. Excision of lesion or tumor, except listed above, dentoalveolar structures, with complex repair. The physician removes a lesion or tumor of the dentoalveolar structures. If the lesion is within the mucosa, the physician makes incisions around the lesion and dissects it away from adjacent structures. If the lesion is within the bone, the mucosa is incised and the underlying bone exposed. The lesion is removed from the bone. The resultant surgical wound is closed with complex repair techniques, such as tissue rearrangement with flaps, tissue grafting, or complex suturing. Excision of tracheal tumor or carcinoma, cervical. Thoracic. The physician excises a tracheal tumor or carcinoma. The physician makes an incision in cervical or thoracic approach to access the mass. The trachea is incised and the mass is resected. If necessary, the proximal and distal portions of the trachea are brought together and closed with sutures. The wound is sutured in layers. Excision of Prasakral or Sacrococcygeal tumor. The physician performs resection of a Prasakral or Sacrococcygeal tumor. The physician makes an abdominal incision and explores the abdomen. The tumor is identified and the rectum is mobilized from the sacrum to expose the tumor. The tumor is dissected free of surrounding structures and removed. Alternately, the tumor may be approached posteriorly through an incision between the sacrum and coccyx. The coccyx is removed, the rectum is mobilized from the sacrum and the tumor is dissected from surrounding structures and removed. A portion of the sacrum may be excised and block with the tumor. The incision is closed. Excision of parotid tumor or parotid gland, lateral lobe, without nerve dissection. Lateral lobe, with dissection and preservation of facial nerve. Total, with dissection and preservation of facial nerve. Total, and block removal with sacrifice of facial nerve. Total, with unilateral radical neck dissection. The physician excises a portion or all of the parotid gland with or without facial nerve preservation and unilateral neck dissection. The physician makes a preauricular incision with a curved cervical extension to the midpoint of the mandible. The anterior and posterior skin flaps are retracted and the tissues are retracted to expose the parotid gland, leaving the fascia over the gland intact. In 42410, the main trunk of the facial nerve is visualized and the lateral, superficial, lobe of the parotid gland is freed and excised. In 42415, the facial nerve is identified and the lateral lobe is lifted off the branches of the nerve using dissection. A nerve stimulator may be used to test nerve integrity. The facial nerve is identified and the lateral lobe is lifted off the branches of the nerve using dissection. The nerve stimulator is used often to ensure nerve integrity. In 42425, the physician removes the gland without capsule disruption, sacrificing the facial nerve. In 42426, the physician removes the gland without capsule disruption, sacrificing the facial nerve. The incision is extended inferiorly to dissect the unilateral neck for lymph node excision.